Hey, good afternoon, everybody. My name is Kevin Shuler, and I'm checking in live from Hartford, Connecticut, at CCAR's Hartford Recovery Community Center. And I'm grateful for the opportunity to come here and just communicate to you all what we have learned in our 7 years of operation as an emergency department recovery coaching program at CCAR. So this is meant to be a collaborative experience. I really want to give everybody an opportunity to share ideas, to add input, to ask questions. That's what this is all about. We're all here to better support the people that we serve. And so whether or not you serve as a recovery coach yourself, you serve as a recovery coach manager, you're serving an organization who is looking to implement a recovery coaching program in your area, I really hope that you are able to walk away with this, with everything that you're looking for. And so a great opportunity right now, if you feel willing and compelled, I invite you to check in where you're logging in from in the chat, who you are, where you're from, and maybe what you hope to get out of this webinar. And we'll just go through this organically, and as things come up, we can certainly process them and really get an idea of what direction we want to take this webinar. So as an introduction, my name is, as I stated, Kevin Shuler. First and foremost, I'm a person in recovery. I've been employed with CCAR since February of 2020, and I've served as the program manager for the past 3 years. Our emergency department recovery coach program serves every hospital in the state of Connecticut, and so it's up for debate, but there's 32 emergency departments that we serve, and we have currently a roster of 16 recovery coaches. Our program operates from 8 a.m. to midnight, 365 days a year. We know that crisis doesn't operate from 9 to 5, Monday through Friday, and so we really aim to serve the population when needed and meet them literally where they are. A little bit about me is I was IV drug user for well over a decade, and as a result of that disorder, I found myself in emergency departments and hospitalizations and treatment centers and other areas where I needed a level of support. And my experience being in an emergency department as a result of an overdose and maybe a Narcan reversal was simply a piece of paper with some resources that I should probably check out and a nudge out the door, only to return back to the environment in which I just came from with more guilt, more shame, fear, and little help maybe navigating the system, or even some tangible connection to help motivate me to make a meaningful change. And so that's what compelled me to get into this work. And I first served as a recovery coach in the emergency department, some of the same emergency departments where I found myself as a result of my addiction. A little bit of a history of this program. Our executive director, Phil Valentine. Thank you, Ray. Our executive director, Phil Valentine, shares a story that in 1987, he was passed a beeper from his 12-step sponsor. And he said, when this beeper goes off, I want you to respond to it. And one night at about 11:30 at night, the beeper goes off and they say, this is Rockville General Hospital, and we have someone here we'd like you to see. And so I make a joke that Phil is the pioneer emergency department recovery coach, and he would go into the hospital and he would just meet with an individual. And I think even our early roots of AA had similar experiences going to Towns Hospital and meeting with individuals who are dealing with a substance use disorder at the time. He told that story to the state level for 15 years, and there was really no action taken. But finally, somebody listened. And in 2017, we started this program. It was started as a pilot program in 4 hospitals, and very quickly hospital staff saw the ability that recovery coaches had to connect with individuals that were dealing with addiction, the ability to take time with them and support them in their needs and connect them to appropriate resources. And so the program really started to gain some traction, and we expanded very rapidly. The state of Connecticut took notice and they expanded our funding. And last year, ultimately, we expanded, into every hospital in the state. So just to pause and to really show the meaning that this program has from a personal perspective, I'm going to ask Travis to share that testimonial that we have. It's about 35 to 45 seconds, but I think it's a good snapshot of some of the impact that this program and programs like it can have. There you go.
Throughout my years of addiction, I overdosed many, many, many times, but I met Barry from CCAR, Kevin. They came to see me at the hospital. They kept reassuring me that I do matter and my future matters and it's not too late and that I can do this. And they motivated me and they encouraged me the entire way. Today I'm 8 months clean. By grace of God, thank you from the bottom of my heart to CCAR. I love you guys. You will forever be a part of my journey. And it just started. I just started. Amen.
Excellent, excellent. And now I know that's just a snapshot, really high level view of some of the impact, and that doesn't speak to everything that transpired in this woman's life to kind of get her to this place. But I just really want to check in with the group and see if anybody has any thoughts on that video, on recovery coaching in emergency departments, or anything that they would like to share.
Hey, my name is Darrell Barnes, man, and that was beautiful. Uh, we I work for an agency called Sobriety House in Detroit, Michigan, and we went into the emergency department at Detroit Receiving Hospital 2 years ago. And the need for us in the emergency department is not being talked about as much as it should be. We went in and we have a 75% success rate of getting people admitted into residential treatment coming straight out of the emergency department. We expanded over to Sinai Grace Hospital. So I just want to say this is some very valuable information, and the work is very needed.
Excellent. Thank you for that contribution, Daryl. And he brought up an interesting point, barriers from hospital staff. And I heard stigma in that. Can anybody speak to some of the barriers that they may perceive could happen with recovery coaches in emergency departments and what some of the pushback may be?
Well, if nobody else don't have anything to add, I love that question because there was a lot of barriers with the staff, nursing department, doctors feeling like we was trying to do their jobs, and what we did was in next month on August the 8th, what they allowed us to do is they allowed us to go in and to educate the staff about our presence there. So every quarter we speak to the residents, the new residents coming in, and what we find out is the residents are also afflicted by substance use disorders and other disorders as well, and they seek out our help as well. So it's been a success as far as breaking down some of the barriers, and we recently was extended over into the mother baby unit. So there's a lot of barriers, but consistency and doing what you're supposed to do to break those barriers down.
Amazing. Thank you, Daryl. Absolutely. I'm going to share an infographic that we disseminate to hospitals and to other community partners that kind of gives an overview of what the expectation is of recovery coaches. So this states that in March of 2017, the Connecticut Department of Mental Health and Addiction Services, DEMHS, that's our single state agency here in Connecticut, partnered with CCAR to pilot an initiative that pairs on-call recovery coaches with emergency departments and 4 hospitals in Eastern Connecticut. With information from the successful pilot and the support of federal grants, the program expanded to additional hospitals in 2018. And by 2023, recovery coaches will be working in all the hospital emergency departments in the state. Here's our participating Connecticut hospitals. And we really want to identify who are recovery coaches because there's a big misconception on what recovery coaches do and who they are. And so recovery coaches are trained, skilled professionals who support patients, family members, and hospital personnel by providing assistance to help people begin in recovery or to stabilize recovery when needed. Coaches are often people with lived addiction recovery experience. Therefore, they demonstrate that people can recover, offering guidance and hope to those who are living with substance use disorders. I'm going to throw a question out to the group. Should a recovery coach have, quote unquote, lived experience to do the work? And I really want you to ponder that. You don't have to answer it right now, but it's something to think about. What do? They assist people who are admitted with opioid overdose or other alcohol or drug-related medical emergencies and connect them to substance use disorder treatment and community-based recovery resources. All right. Does anybody have any thoughts on the question asked? Must a recovery coach have lived experience with an addiction-related issue to adequately coach somebody in their recovery? Are there any thoughts on that? You can raise your virtual hand, you can wave to me, or you can just blurt out an answer. No judgment, judgment-free zone. This is a contentious issue, and I would like to hear if anybody has any thoughts. 3 participants raise their hand. Who we got? Let's start with Jasmine. Jasmine, please.
Hi. Yeah, no, I don't think it's required. I work for a recovery center and I am not an alcoholic or a drug addict. And I do work a 12-step program of Al-Anon. I have lived experience, just a different kind of lived experience. And I don't think somebody has to be considered an alcoholic or a drug addict to be able to help other alcoholics and drug addicts, as long as they understand the disease and recovery and have all the resources.
Very good. Very good. Thank you. Thank you very much. Daryl, you're next up on my screen.
Well, I think it's, it's not required, but I think it's a major plus, because that's just like a person trying to coach a basketball team that never played basketball before. So, especially in the emergency department, when you're dealing with people who have substance use and opioid use disorder, one of the major connections is that lived experience. So I think it's very, 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 very valuable. Not required, but it's 99% on the Richter scale, in my opinion.
Thank you, Daryl. Appreciate that. Vincent from Baltimore.
Yeah, hey everyone. You said you asked a question to adequately help that person. And I believe that lived experience is definitely necessary to adequately help that person. You actually connect with them on a different level. You can, with your lived experience, is what actually gives them the hope to move on, to go forward. So yeah, I believe that lived experience is definitely necessary.
That's a great point. Thank you, Vincent. I appreciate that. Here at CCAR, just for transparency, so we are a recovery community organization, and we believe that the recovery community consists obviously of people in recovery, friends, family members, and allies. And so as a result to test the theory, if allies, or in an attempt to test the theory, if allies can adequately coach and connect and support individuals dealing with addiction in the emergency department, we've hired a couple. And I can tell you that I previously held the belief, maybe just a bias or a lack of understanding, or maybe even an implicit bias, a subconscious bias, that allies would not be able to navigate or deal or connect appropriately with people with addiction. I felt like lived experience brings a level of credibility. And I've been proven, to my surprise and pleasantly, wrong. It's been proven here at CCAR that we have allies on staff who do an amazing job connecting. Now, to Jasmine's point, there is lived experience in that, and I believe that their greatest strength is to share transparently what compels them to do this work and why they are committed to supporting somebody in recovery. And as long as there's that shared understanding and that trust that's formed, hope can be transferred in my experience. And we have seen individuals do really well. We've also seen individuals with multiple years of recovery, decades of recovery, really struggle to connect with people that were dealing with addiction. So I would say that my opinion is that it really depends on the person and the individual. Next, I want to share my screen one more time, and I want to go to our program framework. So when we were starting this program, it was important for us to really delineate and to outline exactly what this program was intended to do. And so we created this framework, and our recovery coach program coordinator is on this call, and she has done a phenomenal job in really developing relationships with administrators and hospital staff, and to really garner that buy-in that is so needed if you're going to be doing this work in hospitals in your area. And so the purpose is to have trained recovery coaches reach out to ED patients and their families with hope, care, and the concept that recovery is possible, and provide assistance when a desire for recovery is indicated. The staff, this was when we started the program, was 1 recovery coach program manager, 1 program coordinator, and 18 full-time coaches. I want you to think about if there is an adequate level of supervision and support with that specific framework, and I'll circle back to that. Our trainings obviously are CCAR specific in many ways, but we have supplemental trainings as we evolve as a program and we try to meet the needs of the people that we serve. We've incorporated mental health first aid, medicated assisted recovery trainings, crisis intervention and conflict resolution, and then obviously hospital specific trainings. Another thing that we do that we feel is really monumental to the success of a recovery coach is not to hire somebody, provide them with these trainings in theory, and just say, okay, good luck. I hope you make it. We really want to pair them with a seasoned recovery coach for a period of time and get them feel comfortable just kind of seeing how those interactions go, seeing how they navigate situations in real time, and feeling comfortable doing that on their own. Where the hospitals that we've already outlined, the coverage schedule. Coaches are available 8 a.m. to midnight, Monday through Sunday, 365 days a year. Who overdose patients are a priority, but any patient with alcohol or substance use reason for an ED visit. This was another contentious issue when we started the program. From a funding standpoint, our funders really wanted us to focus, obviously, on the consequences and ramifications of the opioid epidemic. And CCAR really held their ground on that we would not create a policy that prevents us from doing the right thing and supporting anybody with any addiction related issue. So I will share our data later on to see if that has been a decision that has proven some positive dividends. How? This is the how of the program. So ED staff identifies a patient, they obtain consent, and then they call a third party answering service that we have that will dispatch a coach. The coach will immediately call the hospital and respond in person within 2 hours or less. Coach will engage patient, and if patient needs a detox or inpatient treatment, coach will help find a provider, arrange transport, or transport if needed. Another question to ponder is, should recovery coaches be transporting folks from the emergency department? And should there be any barrier on who they transport? And what are your thoughts on that? Coach will enroll patient in an enhanced telephone recovery support program, and the patient will get called daily for the next 10 days, then weekly if desired. And the coach will be providing recovery support information to the patient and or friends and family. This can include 12-step community, online, and other recovery resources. A fundamental principle of our organization and the work we do is that there are multiple paths of recovery, and we really want to be able to espouse those appropriately. And then CCAR will provide an ED with a prescription pad style resource guide that they can pass to patients who are discharged in the event that they're unable to connect with a recovery coach. Are there any thoughts on that framework? Does anybody have any experience with recovery coach programs in hospitals in their area that they would like to share? Anything that they do differently, or anything on what I just mentioned?
I do.
Yes, go
I
ahead.
do everything at the emergency department. We do everything that you just described, and that was a dilemma as far as us transporting them from the emergency department to different programs.
Mm-hmm.
But it's a personal choice. We do it we do it, but we also have come up with other methods. Some people have insurance that their insurance provider will get them transportation to a agency or home. And the hospital also, our association with the hospital, they also have cabs that are taken to the program. But as far as transporting them, that was a kind of a dilemma, especially if you have a woman, you know, transporting a man by herself, you know, stuff like that. So that was an issue, but we haven't had any problems. So.
Excellent. So thank you for sharing that. Does anybody else see any potential issues or have any thoughts on a policy of transportation of an individual from an emergency department to a treatment provider, to a home? Should there be any restrictions on that? I don't hear any more thoughts. That's interesting. I will share the policy that we hold here at CCAR. And to Daryl's point, it is a personal choice. If the recovery coach feels comfortable and we've exhausted all other modes of transportation for that individual, and there are other resources that can help support that effort, then the recovery coach will transport, regardless of gender or regardless of any other demographic. It's just an opportunity to better connect and support with folks. And I would share some of the recovery coaches' experiences with those, is some of the most meaningful connections have transpired in those car rides to treatment providers. So I believe that it is acceptable when appropriate, but we trust our coaches. We employ them with the ability to make that decision, and there will just be a conversation with a supervisor if those situations occur. The next topic I want to speak about is hiring. So hiring recovery coaches produces many different opinions. Should recovery coaches have formal education in addition to be adequate recovery coaches? Anybody have any thoughts? Should recovery coaches have recovery coach training before they are employed as a recovery coach? Any thoughts there?
I think they should have recovery coach training. Uh, unfortunately, one of the things here in the state of Michigan is that you actually have to have been serviced in the treatment by by SUD treatment provider in order to be recognized as a certified peer recovery mentor. But as a certified peer recovery coach through CCAR agency would give you a certified peer recovery coach credential through the Michigan Department of Health and Human Services if you already are employed at a substance use provider. Me personally, I think I'm smiling because as a supervisor, I've been faced with this dilemma when people call me and say, I want to work for your agency, I want to work for your agency. Unfortunately, like I said, one of the requirements to be a recovery coach in the state of Michigan is to have prior experience with a residential treatment facility.
Thank you for that. Throwing another question out there. This may elicit an emotional response. Should there be a clean time or sober time requirements for a recovery coach? Does anybody have any thoughts on that?
I hate to be the one doing all the answering, but I say yes.
And what should that time be, Daryl?
In Michigan, they say 2 years, but I say a year.
You say a year, so on a 366 day, I'm equipped to be able to coach somebody in the hospital?
No, but I would say out of 365 days, you have experienced enough of recovery and lessons learned in the recovery to be able to pass it on to somebody else. And you have said enough no's and stayed out of enough different places and to be able to coach somebody. That's just my experience.
Fair point. Fair point. Mark Rosso, good to see you.
Hey, what's up, Kev?
Hey.
So, I mean, as long as we're talking about recovery and supporting all pathways to recovery, I would have to say no to the clean/sober requirement, but yes to being in recovery. Recovery looks different on people, and that might include Matt. That might include medical marijuana. That might include a social drink during a holiday. So should that prevent somebody from helping somebody else and being a recovery coach? I would say no. But I do obviously think that person needs to be well established within their recovery.
Thank you for that. Mr. Ed Havlet, I'm sorry, I don't want to mispronounce your name. Havlovich. Do I have it right? Havlovic.
Havlovic. Thanks.
That's what I said. Yep.
Thanks, Kevin. You did. Very good. I agree with Mark. As a facilitator of the Recovery Coach Academy, the CCAR's program, you're in recovery if you say you're in recovery. So as long as I am able to profess that I am in recovery and I am there for a purpose and function, I would have to say, yes, that is fine.
Thank you for that. Absolutely. Anybody else? Anybody else thoughts on the clean time requirement, sober time requirement, if you need to be in recovery to be a recovery coach, or any of those points? Okay.
Hey, Kev,
Yes, go ahead, Barry. Yeah,
want to
please.
put this out there. So if we have a clean time requirement, how would that affect allies of recovery? People who aren't in recovery that are allies that are recovery coaches? Because there are allies and there are, so how would we, like, you know, how would we gauge the clean time requirement?
It's a fair question. Any thoughts on that? And how would we monitor that? Would we want to see receipts of UTOC screenings? Would we want to see NA medallions or AA chips to support your claim that you've been in sober for 5 years? Go ahead, Jasmine.
Well, being the only ally here, I am assuming, we get chips every year, just like the AAs and NAs do. And we have a recovery date that I go by, like I've been in recovery for 10 years.
Mhm.
And that just means working the steps and going to meetings and not hurt anybody.
Absolutely. It's my goal too. Thank you. Ed.
I'm talking to myself. If I learned anything from CCAR, I learned there is a tremendous focus and emphasis placed on ethical considerations at all times.
Mhm.
So with that as the guiding overall rule that I follow, I am not going to place myself, lest I lose my certification as a recovery coach. I do not want to lose that. I am not going to place myself in unethical settings. And I would hope and pray that we have the same respect for ourselves as we do for each other and would not jeopardize what we are trying to accomplish through this program by jeopardizing it or treating it in unethical ways for our own personal benefit. So this is not just a me situation. This is how we as a group of people are working in the recovery field for a purpose, serving a very needed and important group of people. I'm getting off my soapbox now.
Fair point. Thank you for that, Ed. Daryl.
You know, I really want to thank CCAR because it's really opened my mind. And I have to always remember that recovery coaching is taking place outside of Michigan as well. In order to be a recovery coach here in the agency in the state of Michigan, they require you to be absent from substance use. Well, when you said, how do you gauge whether a recovery coach, how do you know? Well, they do random urine drops, at different various agencies. But the reason why I said CCAR has expanded my mind because I realized that a recovery coach don't have to be in an AA program, don't have to be in the NA program. And it made me reflect on myself. I'm not in no program. I'm not an AA or NA or nothing. I just follow the path that's opened up before me to improve my life, to better my life. And if I decide, which I don't, if I decide to smoke some weed, would that stop me from being a good recovery coach? Would that stop me from having the resources that I had yesterday before I smoked the weed? So I don't think it's necessary for a recovery coach to have total absence, but I think it's necessary for a recovery coach to have some stability in their life.
Very fair point. Excellent. And we will speak about that stability and the importance of self-care very shortly. I'm going to speak about hiring and the importance of cultural competence. And so one of the philosophies that we have is that our organization should be competent to support everybody. And so in doing that, we value diversity paramount to just about anything else. And I think diversity gives us the strength to connect with a cross-cultural population. And so I'm just going to show you our recovery coaches and the diversity that's within our program and our organization, and how that allows us to meet the needs of the people that we serve. And I can share with you that on this screen, there are 2 allies in recovery, and I won't tell you who, and you want to be able to pick them out if you looked, right? Maybe you could, maybe you'd take a guess, but you'd be hard pressed to really, actually, we have 3 allies on this, and everybody here holds the idea that recovery is possible. I think that's the one guiding principle that recovery is possible for everybody. And if we have the ability to engage somebody, connect with them, and really just ask them what it is that they need for their recovery, and give them the tools to support that goal, then we're better off for it, and we're a competent program. So that's my 2 cents about that. Hiring has been an ongoing challenge for us, and with the inherent real impact of compassion fatigue and burnout that happens in this role, self-care is something that our recovery coach managers will consistently communicate, and all of our recovery coaches are really armed with the idea that self-care is paramount. And if we are not taking care of ourselves and staying stable from an emotional and mental standpoint, then we are going to be ill-equipped to handle the role. And so does anybody have any thoughts on self-care strategies, or how you would communicate to a recovery coach program the importance of self-care? Travis and I were discussing this concept yesterday, and in that it came, how would you bring up self-care to a recovery coach? And ultimately, what we landed on, and which I feel is universal, is the concept of treating them as their own best resource. And so very frequently, recovery coaches will meet with their recovery coach manager, who we call a coach advisor. And in that will be centered around self-care. And what do you need to effectively do your job? How can I support you in that? And are you willing to communicate to me when you feel like you need a break, essentially? We also have an EAP provider who is very accessible to us. And so recovery coaches have the ability to connect with appropriate resources to support them in their self-care efforts. But I'm interested to hear from the group. Does anybody have any specific self-care techniques or strategies that they either employ personally or that they discuss amongst themselves in their organization? Mr. Mark Grasso.
But so one thing I will say about burnout, at least in my own experience, is for me, it hasn't been something that just kind of like comes on. It kind of creeps up on you until you get that compassion fatigue, and you're not really putting your all into what you're doing. And at that point, it's like, because we talked about, talk to your managers and, try to, do this self-care stuff preventatively, or when we see something happen. Sometimes it's not, you're not able to see it sometimes, and so I think it's important to, on a regular basis, not only, practice that preventative care, but to also just kind of take a step back and analyze, like, what's going on in my life right now. Am I centered? Am I focused? Is my life balanced right now? Or is there, other things pulling my attention that are probably pulling me away from what I need to do?
That's a great point. Thank you so much for that, Mark.
I know working in the emergency department is extremely emotionally draining. And one of the things that I stipulate to my guys is that go see a movie sometime. Take some time off, go see a movie, spend some time with your family, go get a massage, go do something special for yourself to appreciate yourself. So that's some of the strategies that we use.
Thank you, Daryl. Vincent.
I believe Ed was first. Ed was next.
Oh, I'm sorry.
No, go
Mr.
ahead,
Anderson.
Vincent. That's fine.
Beauty before age, Vincent.
Okay, great. Yeah, I believe it's very important to stay connected and to definitely participate in my own recovery. Every day I do something for my recovery. So as far as burnout and compassion fatigue, I just try to stay connected in my own recovery.
Excellent. Thank you very much for that, Vincent. And Ed, my apologies. Please go ahead.
No apologies necessary. I think one of the challenges recovery coaches and people who work in the recovery field face is that that sense of, did they make the right choice in hiring me? And so I immediately do not think of putting in 100%. I always think I have to put in 150% to make sure that it's also your own self-image sometimes that comes into play. I also think one of the challenges, besides, the physical things that we could do for self-care, proper eating, rest, working out, meditation, boundaries, setting those boundaries. But I think many of us forget that one of the key things we do is, if we have a supervisor, we need to talk to that supervisor. We need to communicate and advocate for ourselves. Are there things that we need that we do not have? Are there things that they are being asked of us that is not in our role of responsibilities that we do? Are they asking us to do more and more? And if I am putting in 150% and my supervisor says, wow, that Kevin is amazing, let's give him some more to do, and you get all of these additional responsibilities, will you say something and say, whoa, 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 I'm overloaded the way it is? Many times we don't speak up and advocate for ourselves.
That's excellent, Ed. Thank you so much. Absolutely. It was ingrained in me at a young age that what does a good worker get? More work. And in this role, that more work can be extremely emotionally taxing. And if we are overextending our recovery coaches beyond their bandwidth, we're not only doing a disservice to them, we're doing a disservice to the program and to the people that we serve. And so I think it's extremely important to keep your finger on the pulse of the recovery coach, of the program, of everything that's happening across their roles and responsibilities, and making sure that they're being checked in with frequently, and really encouraging them to use their voice and to speak up for themselves. In recovery, we've been empowered. We've been empowered to utilize our voice. And when we're being taken advantage of, or when we are just overwhelmed or consumed, rather than just kind of hard charging through it, there should be an opportunity for a conversation and better supporting the people that we need. I think our recovery coaches, what we do in this program and what makes our framework extremely valuable and what separates us from analog roles within the hospital system, is not only are we establishing rapport bedside and we're meeting with somebody in their most vulnerable time, and we're really putting forth best effort to connect them to their stated resource, their self-directed path of recovery, but we're also staying connected with them in the community. And so there's follow-ups in the community, and we recognize that recovery is a process, not an event, and that long-term ongoing support, as directed by the recovery, is always a beneficial support. And in those call cases, in those situations where recovery coaches have long-standing relationships, their call list, or their caseload, for lack of a better word, expands, and it gets to a level that is untenable. And we see people that have caseloads of 70 people that they're staying connected with on a weekly basis. And that's 70 interactions that you're having with people that are just trying to navigate early recovery. And so one of the philosophies that we have is that a recovery coach is not meant to be the sole source of support for a recovery. And our aim is to really connect them to the greater recovery community, whatever that may look like for them, and to additional sources of support, and to really arm them with that level of connection and support to take those meaningful steps in their recovery. And the goal is not to be engendered in this relationship, and it is completely directed by the recovery, but the goal is to really expand our support system. I have Ed. Yes.
I have a question, if I may ask.
Please.
You list all of the hospitals there in the great state of Connecticut
Mm-hmm.
who have the emergency system set up for the recovery coaches.
Mm-hmm.
Of all the recovery coaches in those hospitals, are their supervisors part of the emergency room setting, or are they part of, where are they located?
Great question.
The reason I ask that question is, do they fully understand, and have they gone through the Recovery Coach Academy training to fully understand who is this person, where do they come from, why are they doing what they're doing, and what is their function and purpose, and what is their responsibilities, and what do they learn that they do so well?
Phenomenal question. I'll try to approach that one at a time. Okay, so CCAR obviously is a third-party organization separate from the greater hospital systems that we work in. And so there is a balancing act that transpires with the Recovery Coach program working in conjunction with the hospital system, but not employed by the hospital. We are contracted with the hospital, not paid by the hospital. So there's a separation there. It has pros and it has cons. The cons being the hospital really doesn't have the control that maybe they would like to be able to hire, to fire, to amend the program any way that they would like. And the pros are it gives us flexibility and separation from the establishment, if you will. For recovery coach supervisors and for all our recovery coaches are on a track to be RCP designees. And I think we're at right now about 90% RCP designees as a coach. In 2022, we received expanded funding to expand into all the hospitals. And that's where we changed the framework. We went from a program with funding for 18 recovery coaches, a program manager, and a program coordinator to funding for 20 recovery coaches, 2 regional managers, program coordinator and program manager. Those regional managers actually both came with years of experience as recovery coaches. So they already had that on the ground, for lack of a better word, experience of what it is and some of the challenges that recovery coaches experience and a realistic view of how to best support recovery coaches. And so we're really blessed in that regard, that our regional managers, one of them being on the call now, Barry Richardson, who is certainly well versed in all, although it's an unpredictable role, has really experienced just about everything that you can see from a barrier standpoint, from a hospital staff pushback standpoint, from a resistant recovery standpoint to successes, and is able to share and lean on that experience and his relationships with the recovery coaches that directly report to him. So we are really grateful in that. Barry is embedded in our recovery community centers. CCAR as an organization has 8 of them located across the 3rd smallest state in the nation, Connecticut. And it really puts us in close proximity to really just about any of the 32 hospitals that we serve in. So it serves as a hub, a home base, a place where our recovery coaches can work out of and continue that follow-up work that is so vital to this role. And also, for lack of a better term, stay out of the way from emergency departments. So what I can say is that I'm going to share our data in a few minutes, but we are underutilized in this state for the amount of people that we can serve. And we know that because we are privy to some of the behavioral health data collection that happens through the Medicaid payer into the state. So we see the amount of behavioral health presentations that happen in the emergency departments, and then we combine and compare those numbers with what we're seeing. We're still at a high level. We're averaging about 500 to 550 referrals a month for our program. Last year was our highest number of individuals that we served with 6,300, but that still pales in comparison to the need. And so the question becomes why? Why do you feel like recovery coaches aren't utilized? So that's a good question I'll throw out to the group. Why do you think that recovery coach programs are underutilized in not only the state of Connecticut, but across the country or the world as a whole? Anybody have any thoughts on that? Mr. Ed.
I think there's several reasons. I don't fully understand the animal, so I am not going to bother with it. I don't want to take the time to figure out, so it's easier just to stay away from it.
Mm.
The other thing is the emergency departments are clinical based. Recovery coaches and everyone else is lived experience. For you to come in and say, well, are you in recovery? Well, I'm in recovery. When I say it, we'll give a few clinicians fits of not know how to handle that response. So my father used to say, it's always better to dance with the devil that you know than with the devil that you don't know. So they don't know or fully understand recovery coach professionals. And for that reason, it's easier to stay where I am doing what I've been doing for so long.
That's excellent contribution to the discussion, and it's produced a question that I'm going to put in the chat. Okay, as
And
we
that's
know,
just my personal
wonderful
beliefs or thinking.
I want to concur with Ed.
Thank you very much. The question that was born out of that statement was, how do we add value to the hospital system while staying true to the non-clinical aspect of the role? So obviously the first and foremost requirement is that we communicate exactly what the role of a recovery coach is to the hospital system and make sure there's agreement and buy-in that yes, this will add value. But if we are not adding value and it's looking as if the recovery coach is actually creating more work for the hospital system, that would probably discourage them from consistently reaching out to us when necessary. So how do you think recovery coaches can add value to the recovery system or to the hospital system? And that is a question that I have asked myself, and we've seen how, and we see the outcomes. But are we able to really reflect that in data? Can you reflect hope given to someone? Recovery coaches are not working for a treatment provider at CCAR. So it's not like we're going to see somebody in an emergency department and say, I have a bed for you at my treatment center. Come on. That would certainly, I think, corrupt the integrity of what we're trying to do. And it would really go against the concept of a self-directed recovery path. So in many cases, we are at the mercy of bed availability, and we are unable to connect somebody directly to a detox bed or an inpatient treatment provider from the hospital. And the hospital staff can see that as a wasted effort. Well, if they can't get somebody into a detox bed, why even call them? That is what we go up against. Does anybody have any thoughts on that? Daryl, I'll start with you.
Kind of like said what I was going to say. The value that we have in the emergency department just being there and having the knowledge that we have, because the medical profession, most of the medical profession, that's why we going in and give these lectures. Most of the medical professions don't even know how to approach a person who has an opioid use disorder. They don't know how to approach a person to have alcohol use disorder. So most of the time when you approach as a recovery coach, from my experience, when you engage a person in an emergency department, it don't necessarily be for other issues that other recovery coaches may have to deal with. It usually deal with a substance, alcohol, opioids, or something of that nature. And I do work for a residential treatment facility, but we don't send the persons to our treatment facility because that's against Stark's law. We have a PIHP who send them through different agencies based upon their assessment. But I see again, I have been told time and time again. I just received a phone call from the head of the emergency department. Just by our presence, it adds value because it gives hope. As you said, it gives hope to the individuals in the emergency department. And not only hope to the individuals in the emergency department, we relieve some of the stress that the staff have dealing with what they call frequent flyers. The recovery coaches engage them and get them the help that they need. And they don't be frequently in the hospital and causing as much havoc as they was causing before. So they always say, we really appreciate you guys. And they use the term cleaning up the emergency department. So our presence there is the value, in my opinion.
Great thought. Before I get to you, Ed, I'm going to read something we have in the chat from Kathy from Rise and Grind. Love the name of the organization.
Katie and yeah, Rise and Grind, harm reduction.
Katie, I'm sorry, I missed it. I don't have my glasses. I apologize. Thank you, Katie. I believe a lot of folks aren't taking it serious. I think clinical folks don't like that. There is little recorded and shared information. Very fair point. I also think some coaches give people a bad taste. Some are rock stars and keep folks engaged, but a good amount do not. Sorry for late comment. This is why I think coaching is underutilized. Very fair point. Would you like to expound on that at all, Katie? Especially the bad taste. What are your thoughts around that comment?
So I have a bunch of kids in my background, sorry.
It's fine.
I think that, you know, I've had a lot of people that have like coaches that have engaged with people, and just maybe the judgment comes off, especially like if someone is you know, like an ally, right? They're not like a person that's in recovery. I think that that perspective for some people is not so accepted as maybe it should be. I also think maybe people that are allies have a really like bad taste of what substance use disorder does to a person. And I think that sometimes, whether we mean it or not, that like burden, I guess, is kind of brought into sessions, because you know, if someone is on a good path to recovery, right, and they have a reoccurrence, and you know, they sit there for a while, someone that has never experienced like substance use disorder firsthand might, whether they mean to or not, show disappointment or like upset that maybe, you know, they didn't take their advice, or, you know, a million things, right? But I just think that I've seen people get a bad taste. Not only that, but like if someone is, you know, getting off heroin, right, but still drinks, and your coach is an alcoholic, and they maybe try and like, I don't know, be like, hey, you know, drinking is going to be detrimental to like your recovery. Things like that I've seen happen, and it hasn't, it makes people disengage. And I think maybe pairing people up with coaches that like, and that's what coach coordinators are ideal for, right? Is that they can pair coachees with coaches that will kind of like vibe well and have those good conversations, and like those really safe spaces. And I think that falls on the coordinators to really know their coaches well, and to really do like a thorough, like, I guess, intake maybe, or like whatever your initial meeting is when you interact with someone and you're giving them to a coach. Like, being really familiar with your team is really going to be, you know, a priceless thing, because making sure coaches and coachees are paired up in a way that makes the vibe better, is really helpful. You know, I've seen coach coordinators that are like amazing, and they connect people, and the relationship is ongoing. And I've also seen coaches make connection, and it fizzles out. And this is no like down to the coach or the coordinator, but if someone doesn't have that connection, they may not come back to recovery coaching for a while, because they had that, like, I don't want to say negative, but that experience. You know, when you're in early recovery or using, you have so many feelings, and you know, there are so many places you can misstep, and it just you know, and I think coaches need to do a little better at being like, man, I messed up, I shouldn't have said that, or like being really transparent of like, I don't know what it feels like, instead of being like, you know, like, yeah, I know what it's like, and the coachee knows that, you know, you don't know what it's like. So just be like, I have no idea what it's like, but I can empathize with it. I think that's where the bad taste part comes from. And I don't think it's any fault on either party. I think, you know, just knowing your team and getting your art of recovery, of like being a coach, that's real. I think that's all really important and plays into it. I got to go deal with my baby.
Go deal with her. Thank you for that, Katie. Thank you for the contribution.
No
Appreciate it.
problem.
Yes, Ed.
Thanks, Kevin. You asked the question, how can we create value? I think it's more than just creating value. I think an emergency department is part of a giant hospital setting with various layers. And the emergency department reports through these layers to the top. You know, I worked in sales training for years and years in another lifetime before coming into the recovery field. If I remembered anything and learned anything, it was what I can discover that is important to my boss will be important to his boss, because we always work up.
Sure.
So if I don't, and I also think I can see the value of something, but I don't have to give you my commitment and buy-in. I can simply say yes to it. And I think sometimes programs need to be sold in not only as a acceptance of the program, but a full understanding and commitment and embracing it. So when things start to get a little rough, I'm not going to throw my hands up, but I'm going to come in and make sure that it works. So I think finding the value starts at the very low level, but finding the commitment and the embracing of this from the top down to make it work needs to go in hand with each other.
I concur 100%. Absolutely. I'm thinking also from in the shoes of a hospital provider who has an overwhelmed, I'll just give you a little context. Our highest volume hospital in Connecticut is Harford Hospital. Harford Hospital has 110 emergency department beds, and there's routinely 200 people in the emergency department. So people are in the hallways, people are in the waiting room being triaged, and providers have a vested interest to transition them safely through the system.
Yes.
There's somebody who presents with a substance use disorder, and it has been identified that we're going to call CCAR. CCAR, the recovery coach, is working with another recovery 20 miles away, and it's going to take them an hour and a half to be able to respond. So they're waiting an hour and a half for the recovery coach to respond. The recovery coach responds, and it's identified that this person is looking for an opioid detox. And the recovery coach then does their exhaustive bed search and identifies a treatment provider. And the treatment provider needs information on that patient in the hospital so they can make a determination whether or not they're appropriate to be accepted into the program. And so they ask the recovery coach, who does not have access to the electronic health record, ask for that chart to be faxed over. That chart is faxed over, but it's sitting underneath 3 other charts in that person's fax machine. And it's going to take them 2.5 hours to review. And then they're going to call back and they're going to state, this person was just discharged from a detox 4 days ago and does not meet criteria. And so now there's a metric that is utilized in Connecticut called stuck in ED volume, and they want to keep that number down. Hospitals have a vested interest in keeping that number down because it costs more money. And unfortunately, Medicaid reimbursement rates are terrible. And so hospitals are essentially, from a fiscal perspective, losing money serving this population of individuals who are dealing with addiction. And now that person is discharged with no positive outcome or connection to care. And so the hospital doesn't see the value that was transferred in the connection, in the hope, in the support that was provided, and they don't see the outcome that transpires 2 days later when that patient comes to the recovery community center rather than the hospital to receive recovery services. All they see is their volume of that they do not want is increased, and their waiting room is still overwhelmed and filled. And now they have a bad taste, to Katie's point, of a recovery coach. So how do we dispel that myth that it's a wasted effort?
Do they see the reduced number of repeats coming back in for the same treatments constantly? Do they see lower numbers? Does that not bring up more space, more bed, more room? And
Sure.
could that not create value and an understanding for them?
Sure, maybe in a longitudinal data set, but if we're looking really acutely at a specific time frame, say in the month of July, and
Right.
and they do not see that. Go ahead.
This is what just upsets me always. I could go out, rob a grocery store. Within 20 minutes, I am booked, fingerprinted, and I am in jail, and I am having free meals paid for by the tax dollars. If I have a life-threatening situation with an overdose and I come into an emergency room department, and I'm looking for a treatment center maybe or something else, why does it take me 5 days?
That's a systemic issue, Ed.
I certainly understand that. I
Yeah,
think sometimes our thinking is really crossed up in this country.
I agree.
We
I'm gonna,
penalize the disease, and it's painful to watch sometimes.
absolutely right. I'm going to throw in a quote from Don Coyas, the founder of Wellbriety, an indigenous recovery movement. He says, the system is perfectly designed for the results that it is getting. There you go. Thank you, Daryl. So if you want to change the results, what do you have to do?
Talk to Daryl.
Talk to Daryl. And we're going to do that right now. Daryl, what you got?
I was just listening to everything you guys were saying. It just amazed me how different dynamics take place in different parts of the country. And you was talking about how you guys receive a phone call when you need it at the hospital.
Right.
The value that we discovered working with DMC hospitals to have the recovery coaches positioned in the emergency department already.
Sure.
So we got an office in the emergency department to add value to our, that's why I went by our presence. And one of the things that stood out to me when you was talking about the value, I was listening to Ed talk, and it was a story that came up in a maternity ward when a woman come in who's delivered a child and a substance is found. They send the child straight to foster care. CPS comes in. They didn't have no other option. The social workers, they didn't have no other options. But while us being in the emergency department and the word getting around and throughout the hospital that we're there, what happened in this particular case, the social worker came in and they was getting ready to remove the child from the mother. And one of the nurses said, hey, we have a peer recovery coach in the hospital. The peer recovery coach came up with a different option. We knew a treatment provider that would take the lady and her child, her whole family actually. And they said they never knew that this existed. So our presence was our resources that we have is the value that's added to those emergency departments.
Excellent point. Thank you very much, Daryl. Going to share my screen really quickly. All right, I want to really quickly run through this 6-slide deck, the program implementation. When we start this program in new hospitals, this is kind of the framework that we utilize. We establish a contract, a memorandum of understanding. We meet with hospital administrators. There's community outreach. We do not want to operate in a silo. We rely on other organizations that are doing similar work. There's staff education and buy-in. We have frequent huddle presentations to administrative and ED staff. We go through a pretty stringent onboarding process with each hospital. So the recovery coaches, when the hospitals are willing to do so, are badged with that specific hospital badge, so they feel more a part of. There's ongoing regular program feedback. Communication between the manager, the coaches, and hospital staff is paramount. We have a supervision model for recovery coaches that many of you folks have, I'm sure, heard of, and that's called Coacher Vision. Obviously, the expected outcomes, this is what we would love to see happen, and reduce recidivism, fewer return visits. We heard the term frequent flyer thrown out. Obviously, that's a frequent term that we hear, a euphemism, and we've challenged staff to adopt different language, and that's friendly face. And so we do that by using the term friendly face in replace of frequent flyer. We want to reduce substance use disorder related emergency visits overall, which will obviously reduce cost, reduce opioid overdose risk. More people will enter into long-term recovery, increase awareness about the hope, healing, and power of recovery. We want to infuse the hospital system with recovery values and concepts, increase the connection rate to community care, ultimately save lives. Unfortunately for the system, they don't want to hear how we're going to save lives. They want to hear how we're going to save them what? Money. The trainings that we all go through, we don't have, it's a little redundant. We don't have to go through that again. Here's our referrals. These are the hospitals that we are currently in. I'm going to give a clear shot of these numbers in the next slide, but just for awareness, as I stated, Harford Hospital here in Connecticut, we've seen over 4,600 folks since we started there in 2018. A lot of these numbers are a lot lower than would be expected. I would caution you to understand that many of these hospitals didn't come online till maybe about 6 months before this data was fully collected. But we have longstanding relationships with many of the hospitals. The big number here is the total amount of referrals that we saw in our 7-year data, which ended in March 24, was 29,945 individuals that we saw. I'm sorry, did I do something here? Apologize. Okay. Unlike other parts of the country, methamphetamine is far and away the least prevalent substance that we interact with here in Connecticut. It has not really permeated its way into this section of the country. But I would say with a high degree of confidence that alcohol far and away is the most prevalent substance across each emergency department in the country when it's related to substance-related crises. And so alcohol certainly makes up the lion's share of the referrals that we see. And I share this to give perspective to the initial push of only meeting folks who dealt with an opioid use disorder. Opioids and opioid analogs make up over 20% of the calls that we see. And obviously that is something that takes really high priority. But alcohol is longstanding the most prevalent substance that we've seen. And our male to female gender breakdown is pretty disparaging, with 71% being male, 29% being female. So that speaks to the point of something I heard about the coach/coachee relationship and some of the barriers associated with it and the lack of connection. How do we connect across demographic? How do recovery coaches connect across demographic? And I would say that the best way to connect is to treat a person as a resource and to really employ those recovery coaching principles. And I think that's a good way to segue into our next video that Travis will pull up for us. And this is a longer video. It's about 13 minutes, and it is something that we created to highlight the work that's being done in the emergency departments.
I got it ready this time. Don't worry. The right
Thank
video
you.
and everything.
Appreciate you. Thanks.
All right. Just going to share my screen.
One specific thing that I frequently use in the emergency room out of my CCAR trainings is the managing and discovering your own stuff and not allowing my biases to enter into the world of recovery. As a person of a 12-step background, when I often work with recoveries, a lot of people aren't interested in 12 steps, and not allowing that judgment and that bias to enter in my coaching with them. My idea of a coach is to present a lot of options and show guidance, and this is what worked for me, but something that worked for you might be a lot different.
I had willed myself to stop drinking before when I was younger, but as I aged, I couldn't do it any longer. I used to quit for a month at a time, but due to a series of events in my life, but it's not to blame, it's a progressive disease. And the disease it took hold, and I could not do it without help, and I needed a medical detox, which is what TJ convinced me I needed, and he was right there when I got out, and called me every day. I met him at the center in Willimantic at CCAR, and it's just been a wonderful. We're friends. I love TJ. He's one of my closest friends, and he helped me get sober.
My best moment as an emergency department recovery coach is definitely connecting with recoveries and help showing them the long-term supportive care. And coaching is a lot, and building friendships and relationships with people is an amazing thing.
My first 2 years of recovery were at home, staying away from people, and that was the only way that I knew. I didn't know any other pathways. And when I came to CCAR, I learned about those different pathways. I've learned not to get attached to the outcome, but be open-minded to it, and help as much as I can. And some people are not ready. If they're not ready, they're not ready. I never force anybody to do anything, because me personally, it didn't work for me. So just giving them that space, but letting them know that I'm always going to be here. The door is never going to close, and give them time. And they sooner or later will come around to get the help.
When Michael started to text me and call me, it was a source of hope for me that I was now connected. And I wasn't ready to go into a place that was like addiction treatment, because I wasn't ready to reveal that about myself. But I did have one other person, and what I understand now about my recovery is that it's through other people, especially peers, where the healing is. And so it was very, very important to have that for me. It gave me hope.
So the coaches came in as a team gracefully and were understanding that they were new. This was uncharted waters for our region, and they understood that. And they were open to our concerns, but also were working to alleviate those concerns and really educated us on what the model was, because no one knew and we were acting on assumptions. We know what happens when people act on assumptions. There's miscommunication. So they came in and they showed us essentially what they were trained to do and their lived experience and how they wanted to instill the same hope that someone previously had done with them. Communication is key for that to be able to work. And really you see the proof when I connect a person with a coach and then I go back in to check in with them and they tell me how relieved they are to be able to spoke with someone, not from a clinical perspective, but someone with that lived experience who gave them the hope, and their families as well. So really just brung every piece together for that person.
I'd like to think that my staff and I have lots of time to spend with our patients, but in fact, we really don't. When we're really busy, we're triaging patients. And so it's nice when you can offer them an opportunity to really speak with somebody for a lengthy period of time, which is what the coaches are doing. They're really getting to know them. They're talking about their history. They're talking about their struggles with recovery. And so I'm impressed with their ability to connect with them, to develop a rapport with them, and also to follow up with them.
So in the emergency department, we often have few resources to take care of a lot of needs. So this was one more resource that was available for us. So recovery coaches came in, they spent the time with the patients and found a solution and tried to break a cycle of people coming in and leaving and coming back and leaving, and then ultimately ended up with severe medical problems or even worse, in death. And so it really seems like there's a solution, and for patients to relate to someone that's been down the same steps that they've been down.
The idea of treating someone as a resource instead of an object is something that we at CCAR really stand behind. And it's something that could have helped me in my recovery. When I was trying to get into recovery, I felt that I'd been objectified in many different treatment facilities and situations I'd been in when I was trying to work a program of recovery. And being treated more like a resource is something I feel like I could have benefited from. And that's a lesson that I took from the RCA.
I had been clean for 15 years and I had lost touch with recovery houses and everything. And when a crisis hit, I was unable to deal with it. We talked a little bit about spirituality, something I had also given up. And again, he really helped me. I feel like he cares, you know, and that makes a difference, you know. It's not just his job. He literally really cares about me. At least that's how I feel. And it's comforting to know that you have somebody that's there to support you and calls you regularly. You know, we've been in contact now for 4 to 5 months almost, and it's been great, you know.
Any time where someone has long-term success is is one of those things that makes me happy to have the job that I have and proud to be an EDRC.
Being open-minded and open to multiple pathways of recovery, that's something that I really got out of the training here, is the multiple pathways to recovery. You know, MAT, they're still in recovery. You know, you're in recovery when you say you are. And yeah, if I didn't get trained in that area, I probably would have been more judgmental, you know, and now I'm not. I'm non-judgmental, I'm non-biased, and I'm completely open-minded to people in whatever pathway that they choose.
I'm guided by somebody who's been there, who's willing to be honest with me and share their experiences and how they got through it. When I feel like I don't have anybody, I always get a phone call from her around that time. That reminds me that I do. And it's just knowing that somebody cares about you, you know, that you don't even really know. You know, like I got a call that she wasn't available and someone else called me the other day. It was on like a Sunday or Saturday and I was with my kids and normally I'd be upset, but I was extremely grateful by it, you know, because it was a reminder that where I was and where I was at that moment, because I was with my kids doing stuff that I couldn't say I could do 6 months ago.
My best moment is when I can go home at night and lay my head down on my pillow and know that I did a job well done, that I have touched and planted seeds in others and gave them hope.
If you're going to have a recovery coach program, that your plan for supervision and oversight is everything. But it's that intangible piece that gets me. That piece where I think I really don't have that thing, that spark in that person's eye that they get from someone who has been through it.
We use the coaches as they're meant to be, not as another employee or person of the organization. We really want them to spend the time connecting with the patient. The good part about all of this is that people are much freer about talking about substance abuse, and it's not the hidden issue that it used to be. And so really every family is touched by it, and whether it's opiates, alcohol, any other kind of drugs. The whole CCAR concept was awesome because it now added a second layer, a safety net. And so it was really a perfect symbiotic relationship. I mean, our crisis team handles finding places, handles dealing with the patients, does a great job, but also couldn't sit there for a long time and go beyond the initial evaluation, and although they would often, but the CCAR coach would connect with the patient and then continue the connection after discharge.
My fears were, can I do this? Can I connect with these people? Would I say the wrong thing? Would I act the wrong way? You know, those were my genuine feelings at first. But once I got in there and I met these people, these recoverees that were like me, that shared the same feeling, the same adventure, the same thing as I was feeling, you know, I got over that fear. You know, I put forth my best effort to make that connection as we talk. Knowing that there's people out there like me, you know, I knew how to ask those motivating questions, you know, actively listen to these recoveries, you know, and they taught me how to relate. Recovery is always on my mind, and I'm always here to help individuals, recoveries, know that if they're ready for that journey, I'm ready right with you. Just, you gotta let me know though, what can I do to help you with your journey of recovery?
Wonderful. Any takeaways? Anything from that video resonate with anybody? We apologize for the audio issues halfway through the video, but it looks like it was rectified. But I think the point got across. I have Katie had mentioned some things in the chat. I'm going to read this initiative I've used since 2021, and some people have never responded, but still want to text. Some answer 3 times a year when things are tough. How we do that is a system. I don't know, but keep people in the loop. Even if they don't want coaching, let them know there's some form of support. This has been successful in my coaching because not everyone wants a coach when we offer it. It's also been true in our experience. We're met with resistance sometimes bedside, and then we'll see 2, 3, 4 weeks or months later down the road, an individual has found that card and has made a decision to reach out to that recovery coach and speak to them. Ray, thank you for raising your hand. You're up.
Yeah, so I think in the recovery, I think it helps a lot. I'm in drug court, so I'm a recovery coach too. So I'm part of the drug court program that they brought the recovery coaches onto.
Mm-hmm.
And I noticed leading by an example will help a lot to bring people to recover, to help recovery coaches with their problems.
Absolutely.
When you see somebody go through it. So I think but I see the point of like, I'm actually, my mom's in an addiction right now, just so everybody knows. And like, it's hard to watch somebody, even being a recovery coach, that you can't help. You know what I mean? So it's good to see the people that see you doing good and they're willing to open up to you.
That's a great point. Wonderful. What kind of message would we give a coach who feels discouraged that they're unable to help or connect with somebody that they met? Anybody have any thoughts on that? If you're a recovery coach supervisor and a recovery coach comes into your office and they are just discouraged and doubtful and defeated that they're unable to break through or help or connect, or a person that they've been helping returned to use, overdosed, and unfortunately passed away. Katie.
Hey, I'm long-winded, guys, sorry.
Okay.
So I have had this happen. I am a recovery coach. I run an organization, but also I'm certified as a substance use counselor too, which is sticky depending on where you are. But and I'm gonna do this in the counseling area because that's where I've had people overdose and pass away and how people have spoke to me. And I think it's the same, like if you're having issues, either way, I think it's pretty much the same. But first off, I thought I was going to get fired because I had 2 participants that passed away in like a 1-month period. And my supervisor was really wonderful. She was like, you can't control what people are doing. And like, also the drug supply out here, it's poisoned. Like both my people that passed away were cocaine users. They didn't use heroin. They never really did fentanyl. That was not their thing. Their thing was cocaine. And so she was very straightforward of, our supply is poisoned. If people are reoccurring and they're dying, that's not your fault. Also, we can't control anyone's recovery, right? Like and for those of us that are recovery coaches and we have lived experience, we know that, right? We know that we were not doing anything until we were actually ready. And sometimes just reiterating that, like you can be a support, you can love somebody. If they want to use, they're going to use. You may be the only person they have, you know what I mean? And one connection isn't gonna save somebody. Like there's so much more that goes into it. So I think just being really reassuring that like people make their own choices. You are there to be a support, to love, to empower. You cannot make those choices for somebody. I also know, like I have never had someone pass away with my coaches, but if they are, struggling to connect, I like to have like an open-ended question, like, why do you feel that way? Right. And then once I get some particulars of why they're feeling that way, then we dig into that. You feel like you're not connecting with somebody. Why do you feel like you're not, and how can we maybe improve on that? Or that's probably not the language I'd use, but like, what's making you feel this way? I also think that, you know, checking in, where are you mentally? Do you have the capacity for this? Things like that are definitely what I would do. And also, if you're totally disconnected and you really feel like you're not doing anything, you guys are not vibing, things are not good, like it's okay to like say maybe they'd do better off with a different coach. You know, like I know that I've had counselors and coaches and I've been like, I don't like you, especially my family coach when I first started, didn't like her. And I'm bold and loud and don't care. So I was like, I don't like her, so I want someone else. But sometimes that's just what it is. And people are afraid to say that and to be like, you know, if you feel like you're doing more harm than good, we might have to look at that. And that's not anything against your coaching, but like I said before, some people's coaching styles with their coachees just don't mesh. And that's fine. That's not a problem at all. There's so much room for every single type of recovery pathway, coaching technique, style. There's so like any way there is someone to match that. And I just think letting people know that. And as a supervisor, just really standing behind your coach, right? Like, I got your back, no matter what you choose, no matter how you're feeling, you know, you feel like you need motivational interviewing. You feel like you're not like striving at this topic. You know, let's check in, let's do a training, let's do a refresh, you know, and having your coaches back, I think is the biggest thing that I've experienced with like my girls that coached for me. They're my number one, right? Like I've got your back no matter what. And I don't recommend it, but I think checking in with like the participant and being like, hey, how do you feel? Do you feel like this is like a good relationship? Are you getting something from it? And if the participant is also like, no way, I'm not vibing, well, then you know that this is like a two-way street and we need to do something about it. I've never done that in real life. I don't know how I would go about that, but I feel like we can check in with the participant too. Like we can have that open rapport. I feel like it's a slope that maybe you have to learn how to walk, but if you're more transparent with people, people like are more apt to vibe with you. And I think being clear, like I've had to have some hard conversations with my recovery. I've had to be like, listen, I'm having a baby and I've got a ton of kids and I'm not going to have the capacity for this. I know this really awesome person, like, you know, and I've always been pretty well respected for being really transparent and having tough conversations. And I think encouraging your coaches to do that, but also like having their back as a coordinator or a supervisor, you have to have your coach's back above anything else. And, you know, I think if your coach sees that, and also someone mentioned modeling, like as a coordinator, that's where modeling comes in, like in recovery. Yeah. But as a coordinator, it's your job to model how you would navigate this. And I think that's a huge part. Like,
I agree, Katie. I agree.
Yeah, that's what
Absolutely.
I got.
Thank you so much. Appreciate it. Very good. Excellent. We're out of time. I think it's been a great discussion. To Katie's point and to what we've heard before, we usually can't go wrong when we're operating right. Great acronym for right is respect, integrity, gratitude, honesty, and transparency. I think one thing that video reflected was certainly the ability to connect across demographics. I think recovery is universal. The value that ED recovery coaches have on hospital systems by reducing clinical time, taking the time to best supporting individuals and supporting them in their path of recovery. So I'm putting my email in the chat. If anybody would like to continue a conversation offline, feel free to contact me. I appreciate you all for your participation, and we look forward to seeing you again. All right. Thank you all.